So as we talked about in my last panel, HHS this morning just finalized the rule that would require direct-to-consumer advertisements from pharmaceutical companies to require list prices. For those of us who were not on the press call, including me, John, can you summarize that rule and what the department and secretary intend to do with it?
Yep. Well, and first and foremost, I want to thank you and the Atlantic for having us, and everyone in the audience for being here, and really bring the thanks on behalf of the Secretary for your interest in the work that we're doing to lower drug prices and reduce out-of-pocket costs. The Secretary is at the White House on his way to a cabinet meeting. You got the B team, I'm sorry. But what the Secretary described today is how President Trump believes American patients need to know the truth about the costs of their medicine. And we have finalized, really in short order, a rule that would require drug companies with drugs that are covered in Medicare and Medicaid that advertise on television to include the list price of their drug as text in the ad, as well as to say, if they wish, that if you have insurance, you may pay a different amount.
What are the guidelines for that text? Are we allowing companies to also, say, place the range of prices after coupons or after cost sharing?
So we didn't say 12 font Calibri, right? We left it to the people that are very good at designing ads and effective at reaching people to follow regulatory text that basically says this needs to be in a font size and color that is legible. And as Steve said, there's a lot in these ads. And right now, what's in these ads oftentimes says, ask your doctor, you could pay $0. Right, so there's a drug that we see advertised in the HHS cafeteria all the time that is for plaque psoriasis, and it has a list price of about $3,500. That drug is on the formulary of exactly one standalone Medicare Part D plan in the Washington, D.C. area. So if you're one of the people that has access to that drug, because you're on that plan, you will pay the specialty tier co-insurance, which is about 25%. But if you're one of the vast majority of people who aren't, the list price is the price. So that's why we require the list price to be displayed in the ad. And if manufacturers want to say, like, hey, this is what many people pay, ask your doctor. Or in addition to this, go to this website and type in the name of your plan to find out what you'll actually pay. That's a really important way to create the important conversation between the patient and the doctor about, is this drug right for me? Is this drug affordable for me? And are there other more affordable options for me? Because Steve's right, we have a lot of innovation in this country. And as the Secretary says, a drug that's not affordable to a patient might as well not have been discovered.
So what's your hope for modifying perhaps consumer behavior with this?
Well, so this rule is really part of President Trump's transparency agenda. So I think the first thing that you might have heard about was when Congress sent him on a bipartisan basis the gag clause legislation. So the president signed a bill into law that says, if you ask your pharmacist, would this medicine be less expensive if I didn't use my insurance card? The pharmacist has to tell you in either Medicare or in a commercial health plan. You can't be bound by confidentiality provisions in your PBM contract to not do that. The rebate rule that the Secretary proposed would actually create the kind of transparency and reductions in patient cost sharing that means they'll actually like the answer that they get when they ask the pharmacist what the cost of this drug will be. The direct-to-consumer advertising requirement will be one more data point out there, and we have proposed in a Part D rule for next year to require Part D plans to basically work with somebody who can get the real-time pharmacy benefits information. So based on what plan I'm on, where I am in my deductible, what drug is going to be available to me at what price, given the formulary, and not just the printed formulary, but my benefits journey. I think some of the largest Part D plans are already doing this or have the ability to do this today, and we think that's just one more way to create that important conversation between patients and doctors about what's right for them and what's affordable for them.
You don't think there's a risk, and since this is a Medicare form, perhaps for people, say for people who have type 2 diabetes, for them seeing the list price and saying, oh my God, I can't afford this and I'm not going to ask about it at all?
If drug companies are afraid that the price of their drug is going to scare people from asking for their medicine, they should lower the price of their drug. Now, you happen to pick a drug that I think is offering, I can't know actual numbers in Medicare Part D, but I think it's somewhere around 75, 80% rebate across the three different log insulins that are often covered out there. So again, I think having this information out there combined with some of the other transparency proposals, the incentives to lower list price, and ultimately reduce patient out-of-pocket costs, creates a kind of meaningful conversation between doctors and patients and their pharmacists to get on and stay on the right drug for them.
I guess I'm thinking about the lower information consumers, people who are, I think lots of these commercials or have this conversation with your physician or come into the doctor's office. For people who may not necessarily understand what a list price is or does, or what a price after cost sharing is, are there ways to backstop perhaps people not seeking life-saving care?
Well, I think direct-to-consumer advertising plays an important role in helping people understand, do I have this condition? Is there a drug available for me for this condition? They can't just go to the pharmacy and ask for the drug, right? They have to go to the doctor, and that oftentimes requires them scheduling and paying sometimes $200 to get that doctor's appointment and get that prescription. Something that I saw a bit as a pharmacist that may be just as concerning is the patient that comes in with a prescription, has no idea whether it's covered or not, right? And oftentimes one of two things happens. The pharmacist says, your medicine's not covered, right? If you wait here, I'll send a fax to your doctor, and maybe in a few hours or a couple days, we'll find out whether or not we can cover it for you or what's covered for you. But more often than not, even when you give them that information, right? For the drug that I mentioned, even discovering that it's covered, but that it's covered at $1,000 coinsurance means I'm going to go to the glove compartment of my car and say, I'm going to go get my checkbook, and then never come back. And 60% of the time, when that copay gets above $50, like, people don't come back. So lowering patient out-of-pocket costs, empowering meaningful conversations between doctors, patients, and pharmacists about what these drugs actually cost and the value for them in their treatment is important. We heard a lot of people on the Hill talk about the high cost of insulin, and we know that the huge gap between the list price and the price that most people can pay. There are also forms of insulin that are just as effective at treating patients and preventing hypoglycemia and the consequences of elevated blood sugar that are available for $25 or $50 in some instances, even to people without insurance. So if we're only focusing on, hey, this is the only drug for you, and people don't understand that there are other options for them, you hear people say, I can't afford this, and walk away.
What is the secretary and the department's response to the people from within the TV advertising groups who are saying this might just be an incentive to stop DTC advertisements?
DTC ads are very effective, and that's why drug companies do them. We don't believe that there's an incentive here to stop advertising. And again, if you believe that your drug has value and you want to advertise your drug, but you believe that the price is wrong, change your price.
And I do want to open up the floor for questions soon, but what do we have case studies or research that highlights known consumer behavior when we do have list prices listed?
So I call it the Johns Hopkins study because Guy Bai at the Carey School did it, but there were also a couple other researchers at Clemson and elsewhere. They just published some research in JAMA's Internal Medicine Journal, and they found that if you ask consumers, here's an ad for a drug on DTC, how much do you think it costs? They woefully underestimate the cost. But if you give them the information about the actual price of the drug, and you ask them, what do you think you will pay for this drug? They actually describe something that more resembles what somebody would typically pay with coinsurance. So if you give people a place to focus, and they know, like, hey, I usually pay 20 or 30%, it actually empowers them to make a better decision. Now, I think CNN reported that study pointed out a loophole in our ad, which said, or in our regulation, that said, if you still tell people that patient assistance may be available, they will still ask for the drug. Like that was a bad thing. Like our regulation was supposed to stop people for asking for drugs. Our regulation is not intended to stop people for asking for medicines. The regulation is intended to encourage people to ask their doctor about what this drug will do for them and whether it's affordable for them and whether there are other options for them. And that Hopkins study, or the Bai et al. Study, really points out that if you give people information they can act on, they do act on it.
Well, if the hope is that they will be fully informed, consumers will be fully informed both about the list price and perhaps about what their actual options at their provider will be, are we sure it's going to affect their purchasing? What drugs they're asking their doctors about at all?
I'm not sure I understand the question.
If we know that, so this is not a loophole, I think, but if we know that more information in the ads will actually keep them purchasing the drugs or keep them from asking about the drugs, will it actually change list prices?
I think those are two different events, right? Mm-hmm. Like, look, we want America to lead the world in medical innovation. We want prices to be affordable. We want people and prescribers to understand exactly the price of their medicine and how it fits into the value of the care that they're receiving. We also want to change the perverse incentives of a broken system where we see prices go up year over year and everybody benefits from those price increases except for the patient. If I told you that somebody was paying 86% of $30 billion to pick this wheelchair over that wheelchair in the Medicare program, you'd say that's not how any of this is supposed to work, right? But this is what's happening in the Medicare program. And allegedly, from what I heard in the finance committee, the PBMs are telling manufacturers, you can't lower your list price. If you want to lower your list price, you need to give 7 quarters of notice. But the manufacturer alone sets their list price. So these are the incentives of the system that we have. The agenda that was laid out in the President and Secretary's blueprint about 362 days ago really contains comprehensive reforms to fix all of the elements of this system in a way that works for patients, in a way that works for doctors, in a way that works for caregivers, and in a way that continues to lead the world in medical innovation.
All right, well, I do want to open the floor for questions, and I believe we will have a microphone going around. We have a question right here.
Hi, Paul Heldman with Heldman Simpson Partners. A lot of discussion of Part D reforms. I just wanted to get an update from you of the status of proposed reforms on Part B, physician-administered drugs, and in particular, if you could respond to criticisms from MedPAC, among others, that the international benchmark pricing model is unworkable.
Well, so last fall, HHS did some research and found that, by and large, for the most expensive Part B drugs, the ones administered in physicians' offices, we are paying about 180% of what other wealthy countries are paying. We don't negotiate in Medicare Part B. We're a big dumb payer. We get a bill. The bill says the average sticker price plus 6%, 4% and change for those of you scoring the sequester at home. And we pay it. And more often than not, there's very little room between the list price of the medicine and the average sales price of the medicine. So we put out the International Pricing Index that said we want more vendors to help compete for Part B drug costs. We want to do so in a way that makes doctors whole and respects the fact that they didn't choose the current system, but they're invested in it, and they're going to need time to change. And that the United States, if it continues to pay 26% more after a 5-year phase-in than what other wealthy countries are paying, we don't believe that the risk to companies no longer selling their drugs in the Medicare program or some of the other scary things that we've been accused of are going to happen. It was a complicated advanced notice of proposed rulemaking. We got around 3,500, 4,000 comments shortly before the holidays. We read them all. We're incorporating that feedback, and I think, as the administrator has said in a number of settings, we could see a notice of proposed rulemaking this spring.
Right here.
Hello, my name is Blaise Springfield. I'm with Georgetown University Medical Center. We heard Steve Ubel talk about getting the discounts to the counter and having the patient experience that, but to me it seems that if we pass that discount at the counter, that doesn't mean that price isn't going to get absorbed into a patient's premium, and that at the end of the day what they've spent on their healthcare really is going to be the same. It's just what they feel at the counter might be less than $50, but their premium is going to reflect that the insurance company or the PBM didn't get the discount ahead of that. So sort of what's your perspective on that, and what's stopping that from really ending up saving the patient in total money at the end of the day?
So first of all, I think a number of actuaries have unpacked this, and actuaries are good at math. They're not always as good at predicting the response of businesses on public policy. I think in 2004, the Congressional Budget Office warned that the Part D premium in 2013 would be $58. It was $32.17. And it may be because of this system that we have where rebates paid on drugs that are used by the sickest beneficiaries are causing them to pay more at the pharmacy counter and subsidizing the premiums of the healthy people who use less medicines or less expensive medicines. We had 3 actuaries look at what was proposed, and we saw a range of effects from this could save the government $99 billion as a result of Part D plans negotiating more aggressively with manufacturers, e.g. not taking this lying down, or drug companies immediately taking 20% of the rebate, putting it in their pocket, and then ultimately increasing their net price, and that was projected to cost the government $196 billion. I can't for a minute, when 4 PBMs control about 85% of the marketplace, believe that they're going to allow drug companies to maintain their formulary position while increasing their net price and pocketing their rebates. Now, even the highest cost estimate by the actuary said premiums would go up about, say $5 a month. The average Part D brand drug is about $300, and you assume a 30%, 25%, 30% rebate on that. I would be happy if my mom's Part D premium went up by $5 a month, if it meant that she would save $120 on the first fill in January and the second fill in February, on up until she reaches the ICL phase of her benefit. So, and that's the point in the conversation where smart people like you say, oh, well, what if plans change their benefit design? It's like, yes, exactly. And that's why it's really hard to predict just the mathematical effect of taking $30 billion of rebates and assuming it's all going to flow to premiums. So I think that ultimately this will cause Part D plans to negotiate more aggressively. I could show you examples where there are two high-cost drugs on the same tier, and you wonder, is that because of the rebate, or is that because they think they should both be there? And ultimately, I think those are some of the behavioral decisions that we'll see play out.
Before we go, I do want to follow up. As a journalist who wants to have on his calendar the next press call, we talked all day about this panel about DTC rule. When can we expect more movement from the administration on the drug rebates?
Oh boy, we're moving every day on all the policies that were outlined in the blueprint, which incidentally, I think many people laughed at a year ago and said, oh, this is just an RFI, there's 163 questions or 164 question marks. The secretary has turned those question marks into check marks, and by finalizing a rule today, I think we've added an exclamation point. And I assure you that the next time there's a rule coming out, we'd love to be back, and we'd love for you to join our press call.
Well, thank you for inviting me to the press call. All right, and thank you all, and thank you, John.